Hello, everyone. Welcome to Informatics Grand Round. We're thrilled to have so many of you joining us today from all over the globe. We have a fantastic speaker lined up for you today, Dr. Brian Hasselfeld. Before we get to introducing Brian and his talk on telemedicine at scale, the pandemic accelerates change, I'd like to quickly introduce myself, Ash Davison, General Internal Medicine faculty here at Hopkins and in Health Sciences, Informatics, and Health Policy and Management. What a year it's been. Last year at this time, we were getting ready for our holiday party at Hopkins, and we were hearing about the potential of telemedicine from Dr. Jonathan Thierman at LifeBridge Health. What a difference a year makes, right, everybody? We are thinking of all of you, no matter where you're joining us from, hoping that you're safe and well. And at this time, I'm actually going to briefly hand it over to my colleague, Leadership in Informatics Education, Dr. Paul Nagy, to talk a little bit about some of the progress that's been made during this time period with the education program. Because Paul's too humble to mention this, I am going to share on his behalf that this past week, in addition to being course faculty, deputy director of the Technology Innovation Center, he was awarded a National Service Award from the American College of Medical Quality. So congratulations, Paul. Take it away.
Ash, thank you so much. So it's amazing. We are almost finished with quarter 2 of our classwork. So keep up the great work everybody's doing. And I wanted to share, we have done a lot of planning, and we've got some exciting new changes in our curriculum for the first starting in January. We have a new course on clinical decision analysis that Harold Lehman's put together that's going to be talking about how to build Markov models and decision trees. And this is really how clinical reasoning is done. And so it's going to be a great class on how we encode guidelines into healthcare. I have also really revamped my course on Python and clinical data analysis, and I've revolved it around the OMOP model, which is really the de facto data model for working with medical records and claims data. And I feel it's an important thing for our students to be able to be exposed with and to be able to be comfortable with as they go out. And we also, it's in quarter 4, we've got we've done a big revamp on our natural language processing course, which will give you a lot of hands-on exercise for pulling structured data out of narrative notes. And lastly, I'm excited to announce we're going to be teaching a class on implementing FHIR, which is another super important clinical interoperability standard where you're going to get hands-on access to FHIR servers and gain some much needed skills in how to be able to how hospital information systems work and communicate data back and forth. So it's going to be an exciting new year.
Yeah, fantastic. Thanks so much for sharing that, Paul. We, again, have been making significant strides in modernizing the curriculum, and we're thrilled that Dr. Lehman, yourself, Brant Chi, and other faculty are really leading the way in introducing new opportunities for the graduate students. For those of you that are joining and that are eligible for continuing medical education, you can go ahead and text code 31015 to number 443-541-5052. So if you're eligible for CME, I just got my CME credit verification right there. That number is eligible for the next 8 hours. So at this time, without further ado, what I would like to do is welcome our faculty member today, Dr. Brian Hasselfeld. He is the current medical director for digital health and telemedicine at Johns Hopkins. He's been focusing on digital health, virtual care, and clinical innovation long before he even joined us here at Hopkins. We're thrilled to have him serving as a primary care physician in internal medicine and pediatrics for Johns Hopkins community physicians. In addition to his experiences here, he serves on the board of directors for a regional Medicare Advantage insurance plan and has really been a powerful force in education, leadership, and change management. Prior to coming to Hopkins, he completed his residency in internal medicine and pediatrics at Harvard's Brigham and Women's Hospital and Boston Children's Hospital. He also served as the program's chief resident, and he completed his MD at Tulane, where he was a Junior Alpha Omega Alpha honor member. And Brian, at this time, thank you for sharing with us all that's been going on during the pandemic and how it's accelerated change with telemedicine.
Great, thanks, Ash, and congratulations to Paul as well, and thanks to the Informatics team for inviting me here. Happy to share our transformation story here over the course of the last eight and a half months. We'll go ahead and just quickly cover a couple of housekeeping items, some quick disclosures. Do hold an equity interest in a digital health company, and as Ash mentioned, serve on the board of a local Medicare Advantage plan here in Maryland. So what are we going to try to tackle? Transformation and uptake in telemedicine across our large health system population. We'll dig into a number of sub-bullets and sub-components to that one large topic. And then at the end, we'll cover some of the legal, regulatory, and payer reimbursement changes and challenges here as we look to see where telemedicine will be headed as the pandemic evolves and hopefully as we evolve out of it in mid-2021. A little bit deeper dive into our outline. We'll be starting with data. And highlighting some of the lessons learned so far. We'll be highlighting some areas where we've invested in education, and not just education for our trainees and providers, but also for our patients. Discuss some of the things outside of the standard telemedicine visit, both innovative care models that have leveraged technology as well as new technologies. Touch on always the most important aspect, how the patient feels about what's happened here in our care delivery system, and then end with some of that legal, regulatory, and payer areas that will need to be considered as we continue to navigate this space. I'm going to jump right into the graph that I think is most impactful to really understand the scale and scope of what we're talking about here. This is Johns Hopkins Medicine's total telemedicine ambulatory volume, July of 2019, which is our fiscal 21, so that's on the left, all the way through till the end of November here, 2020. Our total telemedicine ambulatory visit volume, 50 to 80 a month prior to the pandemic. You can see from July to February, we had a total of 539 total encounters. And those were encounters as innovation and change typically is, early adopters on the provider side, clinicians of all kinds who saw an opportunity, wanted to build a targeted telemedicine program for a specific clinical need or patient population. In our Office of Telemedicine, founded a number of years ago to focus on those type of projects, would help take that project live. But again, very targeted, early adopter, bottom-up approach. And then March, beginning really Monday, March 16th, everything started to change for how patients and providers access each other. And the healthcare delivery broadly changed, both here in Maryland and in the District of Columbia and in Florida, where we operate and deliver care, but across the country. And you can see that here. We went from 50 to 80 a month to 5,000 a day, 90,000 plus a month in May and June. And split between both use of audio only or phone visits, as well as video visits or synchronous audio video visits. That percentage of phone has decreased over time as we've invested in technology and education around technology, but still remains significant. We'll get into some of the data around how different kinds of patients are using audio versus video interactions. You can see that in September and October, relatively flattened out. September and October were our most open months, I think, as a delivery system, where the pandemic was still in a simmering stage and more procedures were being done in the hospital. November is starting to tell a different story. It doesn't look like it here, but on the next slide, we're going to get into the week by week change, and you'll see it a little bit more explicitly. The orange bars highlight holiday weeks where we're open less for ambulatory care, so you'll see them as outliers. But you can see the week over week change that mimics that month over month change, beginning again with that Monday, March 16th and moving forward, peaking at over 20,000 visits in a given week. Interestingly, we started to see a change here in early November, whereas in April and May, our volumes increased as COVID increased. And then on June 1st, Maryland broadly started to reopen restaurants, businesses, but also healthcare. And so we started to go back down again right after that Memorial Day orange bar. And you can see the slope start to go slowly back down. And then September, October, we were flat with about a 0 to 1% change week over week there. Interestingly, early November, for 3 consecutive weeks, we saw our first sustained week over week increase in total telemedicine volume. Now, as we continue to gather more data, what I feel we're going to see retrospectively is that use of telemedicine, the real-time choice by providers and patients to choose to access through telemedicine versus booking in-person care, reflective of a lot of variables, but I think it will be a real-time marker for case incidents in our regions. And we're seeing that anecdotally now, and we'll start to see it objectively as more and more data rolls in. But telemedicine volumes clearly are moving somewhat correlated relative to new case incidents in our regions. And we'll be continuing to be tracking that as we move forward into December. Digging into how this compares between telemedicine volume and then in-person volume. And then a solid blue line across the top is kind of our pre-COVID previous fiscal year total ambulatory volume average, to give you some context for amount of care. Obviously in mid-March, things dropped off a cliff, but you can also see that the blue, the telemedicine, and these are stacked together, so they're additive. The blue through March, April, and May was over half of our total ambulatory volume. That includes ambulatory volume like radiology and lab and infusion, things that are really not replaceable at this point in time via telehealth. More than half of our total ambulatory care was delivered by telemedicine through those core months. And then as telemedicine went down, slowly, in-person care ramped up significantly and settled off that total telemedicine volume was about 20% of total care. But when we dig into the data a little bit and remove some things that are telehealth insensitive, lab, radiology, et cetera, in October, November, telemedicine care still remained over a quarter of total care, even when broadly access to care was open for in-person care. Probably a varied amount of reasons behind that, but certainly fear of infection, risk of infection and exposure, but also, the new component of patient convenience and online access certainly now is front and center as patients are thinking about how to access the healthcare system. And as I said in the outline at the very end, we're going to get into the patient perspective on that. Wanted to touch here, though, that oftentimes when I talk with both state and federal policymakers, insurance companies, the focus always immediately turns to, all right, well, telemedicine is great for mental health, behavioral health, and a lot of people immediately understand why that may be, right? Talking may be different than certain things that are physical exam intensive. Maybe it's relevant for primary care, but that's where we should focus. And I think I just want to put a few bullet points up here on the screen. This is percent of total ambulatory care in these divisions and departments in October that were done by telemedicine. So mental and behavioral health, 84%, makes a lot of sense. Nutrition, so not something that's in necessarily primary care or mental behavioral health, but when you think about it, it makes a lot of sense, obviously. Nutrition counseling relevant for diabetes and endocrinology, obesity and weight management, primary care, a lot done by telemedicine. But our neurosciences divisions, neurology and neurosurgery, both nearly 50% telemedicine. In neurosurgery in particular, preoperative assessment, evaluation, postoperative wound evaluation, all feasible in certain clinical circumstances through telemedicine. Primary care, obviously a leader. And then, it's not all telemedicine all the time. Ophthalmology and the fundoscopic exam, maybe not yet so suited for telemedicine, and they're at 0.3%. But it is spread out across all of our divisions and departments. And it's really not a question of what kind of specialty is appropriate for telemedicine, but more so what kind of clinical questions inside of every specialty are appropriate. In some specialties, it's more clinical questions than others, but definitely relevant across all of our divisions and departments. And this has been a testament to all the providers and staff, front desk, nursing, MAs, social workers, and physicians and advanced practice providers who have committed to really delivering a new type of care so quickly.
Brian,
Yeah.
One of the questions that was sent in was, despite the feasibility of introducing virtual care delivery in each of these different specialties, can you speak a bit about some of the unique challenges to redesigning the workflow in one specialty versus the other?
Absolutely. I mean, so there are some really straightforward concepts like a lot of our customized processes for bringing a patient into clinic are very much human driven. So front desk staff and medical assistants and nurses are trained in their discipline the same way that physicians and advanced practice providers are trained in their discipline. And that extends to knowing which type of history questions to ask, which type of questionnaires are relevant, what kind of updates for standardized disease-based questionnaires should be done ahead of time to specific follow-up. So in primary care, we do, a lot of lab and radiology, but in other areas, you have different types of procedural referrals and local testing, physical therapy sites, et cetera. A lot of that knowledge is local at the site, and not physician local, but administratively and operationally local. And so trying to translate all of that local knowledge to technology and allow it to be an opportunity for efficiency, but it does, reinforce that a lot of investment is local at the clinic. That's a practical operational consideration that varies across every division and department, as well as each location of each division and department. Clinically, obviously, there's some things, and we'll touch on a few of these that there are, and this is why I do challenge that it's not just a kind of specialty, but it's clinical questions under a specialty. Certain areas require certain aspects of patient interaction. That's obvious. The physical exam is important, no matter whether or not some providers think it is or isn't, it's obviously important. And so executing on certain aspects of the physical exam are more important in certain kinds of clinical questions than others, no question. And so thinking about how we will create technology and integrate technology to execute on those physical exam findings is an important challenge in pediatrics. So, Ash introduced me. I do practice internal medicine in pediatrics and see both adults and kids in primary care. In pediatrics, what's one of our top fall and winter complaints, during regular viral season, not COVID viral season, ear pain and fever, and the need to look at that tympanic membrane and that and look inside the ear. Sore throat and look at the back of the throat for strep throat, right? So there are absolutely specific physical exam findings that are unique to each specialty and may require specific tools. And we'll touch a little bit on where we're starting to go in that direction later in the presentation. All right. I'm going to step away just from the volume by division department and actually touch on volume by geography. And so Hopkins, as I said, we have hospitals and buildings in 3 places in Maryland, obviously, but also in Washington, D.C. At our Sibley hospital. And then down in Florida as well, we have Johns Hopkins All Children's Hospital. We have delivered over 54,000 telemedicine visits to patients located outside of those 3 geographies. That's about 9% of our total volume. But and you can see here, it's very much a national reach. We've actually touched every state in the union, but it's also regional and concentrated regionally, and that makes a lot of sense. Patients from our whole Mid-Atlantic region often drive to Hopkins to receive certain kinds of specialty care. That's reflected in the 3rd bullet point here, that 4 of our border states, Virginia, Pennsylvania, Delaware, and West Virginia, make up 85% of our total out-of-state volume, that volume that's outside of Maryland, Florida, and DC. And we'll touch on some of the public regulatory changes that have made that feasible on a state-by-state basis, but does highlight that patients want to access their clinicians. Sometimes their clinicians are arbitrarily separated from them by a state line. And we need to think about both technology and policy that may facilitate ensuring patients continue to have access to their clinicians virtually when clinically appropriate. Going to dive into some of our newer data. And so we are working closely with our Center for Health Equity, as well as our Office for Diversity and Inclusion, to think about this course construct. And some of our state affairs team members, I think, coined this phrase. I'm stealing it, which is that telemedicine and digital health, if done well, has an opportunity to address healthcare disparities. But if done poorly, may very well exacerbate them. And I think what we're seeing here is that this broad transformation and transition to telemedicine has highlighted a couple important aspects, that access to internet specifically broadband internet, either cellular or wired or connected, is a growing important social determinant of health. And the reasons why you may have difficulty with accessing broadband internet may vary. And we've called out some of our early data here. So going graph by graph, this is broken out in that bucket that's identified here. What percentage of their telemedicine visits over the course of the last 8.5 months have been done by video, which requires that broadband internet access, either cellular or wired, or by audio only or phone, which is a different kind of technology access, obviously. And at the top, we see the progression by age. Many would probably hypothesize that this graph would look this way. In pediatrics, which is most often, sometimes not in the adolescent age range, where adolescents can seek care independently in some circumstances, mostly reflecting the technology access of the parent or guardian. And then as we progress through the age brackets, that in the 75 and up, we have a third of the total visits being done by phone, relative to all the way down to 5% in the newborn period, again, with younger parents by and large, or guardians overseeing that care. Same breakdown by reported preferred language. So this is who you as a patient, you've identified, this is my preferred language. English speaking patients with identified English as their preferred language, 19% phone. Then you can see the breakdown across other languages. You can see Spanish, 28%, Chinese Mandarin, 25%, Arabic, 31%. Technology platforms are built English first. That is a new, it's not a new issue, but it's a newly important issue, again, as access to technology becomes a more and more important social determinant of health. Most of our patient portal platforms have Spanish as a secondary default language, but after Spanish, it becomes progressively difficult. So how do we continue to design systems that are oriented to multiple different kinds of languages? One area that we have had success, though, and potentially an opportunity in engaging in virtual care, is it is now easier to dynamically allocate interpreters, human interpreters, to different kinds of interactions around our big, geographically diverse healthcare system. Less and less important, again, to deliver interpreters physically into the room, and obviously not possible for virtual care. And at the bottom, we see a difference between commercial insured patients and then Medicaid, self-pay, and Medicare, all who are generally about the same in percent phone, and perhaps a correlate to socioeconomic and age. Socioeconomic in Medicaid and self-pay, and age more so in Medicare. But nearly a 3 times difference in percent breakdown for phone versus video. And then just calling out some of the things that we need to be cognizant of, and certainly things that our Office of Telemedicine are acutely focused on, and working with the experts in the fields here at Hopkins to think about how can we both address these issues, support these issues, and we'll see some areas that we've invested in here, but also we're starting to get a socioeconomic, social determinant picture of what it may mean to have a hard time accessing telemedicine. So just calling out on the right-hand side, it can be a predictive issue, an informatics issue. Can we create that profile that says, instead of a profile for in-person, are you going to be a no-show, which we do all the time to try to have to optimize schedules? Are you going to have difficulty accessing the video platform? And we can start to learn what makes up a potential patient where it may be harder to access, and then invest in those areas. Here are some of the areas where we've invested. So education, both patient-facing education as well as provider-facing education. You'll see this is our patient-facing website at the top. You can see it both in English and then available in Spanish, both for video visits and telephone visits. But providers, this is Judy Gringle, one of our community physicians, nurse practitioners, produced patient-facing video content with multilingual captions and subtitles as well, to help teach patients, here's how you can consume telemedicine. Here's what you should do to get ready. Here's the environment that you should be in. Don't be driving your car, for instance. But also, if you have a blood pressure cuff, take a blood pressure beforehand. If you have a scale, take your weight beforehand. Have that information available and ready. We've invested in all this educational content, but we've also invested in new types of support. So instead of just having scheduling phone number and our patient portal, I forgot my password phone line, we now need a lot of other types of support. So a dedicated video visit support line to help troubleshoot. And then, as I said, rapid training for all sorts of staff, front desk, MA, nursing, and primary provider. To, unfortunately, for better or for worse, we've all added IT troubleshooting to our job description as we've navigated this transformation.
Brian, that's actually a great segue to, we're getting some great questions posed here. And one in particular is coming from Matt Williams, who's with Futuro Health and has a significant interest in promoting workforce development and, has been able to partner with the informatics education program to increase the number of entry-level support staff to be involved with all this IT troubleshooting. And as it relates to your previous slide on issues of access and here with patients, the question from Matt is, with the increase in telehealth visits, how much dialogue is going around with concern about individuals that might not have insurance, who might be trying to substitute, patient A is, coming in for the encounter, but it's really patient B who arrives due to a lack of insurance. Is that something, you mentioned policy, et cetera, that's on the radar of concern? There's so many things going on, but that's a question from Matt Williams.
Yeah, absolutely. I mean, as with anything, but especially as we start talking about federal policy as well as state policy, fraud and abuse and the potential cost of fraud and abuse becomes a primary question that I think everyone is, correctly, concerned about. I'll say that there's going to be a balance of access to convenience against the potential for fraud and abuse with any expansion of technology for access to clinical care. We've existed in this environment, though, to be clear, for a while, ever since a patient portal became a way to access your clinician. So send a message in through the patient portal, no clear way to know for sure that the patient is directing that question. In some ways, video visits in particular are actually an improvement into some of that patient portal oriented asynchronous care in certain ways. Visual affirmation and confirmation that the patient you're caring for can interact with you directly, visualize the patient. We have implemented our standard identity affirmation processes into our video visits, confirm the name, confirm the date of birth. MyChart is a really secure portal access point for patients to enter into our visits. And because of that, we've built an integrated video offering where patients go through their patient portal to access most of our video visit care. And that will ultimately become the only way to access video-based care after the pandemic. We've been a little bit flexible in platforms due to a variety of HIPAA-based waivers from the federal government. I think all that decided to say, it's certainly on the radar. I think we'll need to advance our protections over time around the fraud and abuse question. One important point is that total volume, even when clinics and the state of Maryland were broadly open August, September, October, in the ambulatory space, when combining telemedicine and in-person care, did not significantly overshoot, right? So it wasn't additive. It was that patients were choosing, this is a more convenient option I will replace. And I do think we saw more so replacement than additive, but it's another kind of core metric that we'll be watching to understand, is there extra utilization? Is there duplicative utilization? And that's certainly an important aspect of the data analysis that's going to have to happen after we have some time to take a look back. And Ash, we can continue to address questions as you and Paul think are appropriate, but we'll dive in, I think, into the next slide here. Other investments. So many are aware of Hopkins as a school of medicine and our educational mission and educational history in this country. Again, as a part-time pediatrician, and our Harriet Lane handbook is on the desk of most pediatricians around the country. It's an opportunity to extend that education mission to the country. And we've started to do so with the leadership of many, Maura McGuire in particular, and a number of our subspecialists. Learning to how to apply clinical exam methods and modalities by video to the day-to-day clinical interaction from those dedicated subspecialists. So specialists in ENT, cardiology, and pulmonology, applying their discipline and giving expert advice on how to execute certain exam maneuvers by video so that we can really expand what you can do clinically, both at the trainee and attending physician level and provider level through telemedicine. Again, going just beyond the Zoom interaction, but moving into the physical exam space as well. It hasn't just been about ambulatory care, though, and we'll highlight a few of those aspects here. Use of telemedicine and use of interactive video has been important, especially in the pandemic, for a variety of reasons. As I said, we're an educational institution. We have a teaching mission. Those of you that have ever rounded in a hospital that's an academic hospital often know that those rounds involve 15, 20 individuals, medical students, trainees, attending clinicians, nursing staff. And obviously in a physical distance world and an infectious disease world, not always possible. The ability to extend rounds to trainees and medical students virtually. The ability to extend that care to family members with new visitor restrictions and policies that restricted the ability of family, which we know is an important aspect of inpatient care, and inpatient care progression has been critical. We've invested in and are continuing to invest in ways to enhance our ICU monitoring for a variety of reasons, both because we feel it's strategically important for data and analysis and clinical care improvement in the critical care setting, but also because areas of our hospitals that weren't ICUs before are handling critical care level care now, and the ability to dynamically extend enhanced monitoring around the hospital has been important in ensuring we have access to the right amount of data for critically ill patients. And again, teaching on ways to enhance all of those tools for our medical student rotations in particular, as well as our trainee interactions. It has been important as well for workforce flexibility. Certain consult questions can occur remotely. Not all, again, it's never an all or nothing question, but in an area where, for instance, a dermatologist may cover multiple hospitals in our region, the ability to answer questions from afar in an inpatient setting, or if a particular subspecialist is quarantined but otherwise safe for work, developing policies and procedures around how to apply those skills and those clinical tools remotely has been an added benefit of using technology in the inpatient space.
Great. So, Brian, one comment that was made by Dr. Todd Dorman, Senior Associate Dean for Education Coordination and Professor in Anesthesiology, Critical Care Medicine, along with many other hats that Dr. Dorman wears at Hopkins. He was writing that, Hopkins really has shown in the late 1990s itself that telemedicine can be done even for ICU patients and families. So really pointing out, as you're talking about lessons learned, that, at places like Hopkins, fortunately, there's been decades of experience here. So thank you for that point, Todd. And one thing that I'm going to go to as you're talking about, facilities and moving from outpatient to inpatient, Brian, a question that comes from Stephen Miller, who is a pediatric gastroenterologist here at Hopkins, one of our graduate students in the online applied informatics program. Dr. Miller writes, another workflow question. Right now, facility fees are not available to cover the time of medical assistants, nurses prior to telemedicine clinic visits for things like medication reconciliation or post-visit counseling by nurses. Critical for some specialty fields like pediatric GI, where families have to handle complex care tasks like G-tube management at home. Is there any advocacy happening to get this support staff time covered through a telemedicine facility fee of some sort?
Yeah, so this is a very unique public policy question, one that's very unique to, that has a unique answer for Maryland. And we will touch on this at the very end when we talk public policy, but just in brief, Maryland has it's the only state where we have a unique waiver with CMMI, the innovation arm of CMS, for how we handle different types of reimbursement and care. And that actually in the pandemic has been a benefit to our state and to our hospitals. We have a fixed global budgeted revenue, or a fixed amount of dollars that are targeted to exchange hands from payer to hospital, which is inclusive of facility charges in any given year. And fortunately, that is to our benefit during a year where care in and out of the hospital is fluctuating by volume, up and down. And also here in the space of telemedicine, where Steve is absolutely right, that individual encounter cannot also charge a facility fee or a fee for the investment in the space and the non-professional service associated with that care. However, the benefit of being in what's really a capitated facility arrangement in our state, for this fiscal year, we will be made whole through through that global budget revenue process. It will take some time. That leads to a separate future question that we get asked all the time in the public policy space. How will we think about cost parity between telemedicine care and in-person care? And how does that differ between areas that have professional fees only versus areas that have professional fees and facility fees? And how will that evolve over time? And I think that's an open-ended question. It's absolutely an area where we have a lot of advocacy ongoing, both in our state as well at the federal level, to think about how we navigate that over time. But I'll do the short answer is, in this fiscal year, which ends June 30th of 2022, we have the benefit of a capitated arrangement for our facility charges. Always can dive deeper into that outside of the lecture. Paul?
Oh, thanks, Brian. So a couple of questions around. So this is really fascinating to see that residual 25% and seeing what's going to happen there. Now, if you're an internal clinician at Hopkins, you could see what type of televolume is being done within your department through some sort of through Epic, or I'm just wondering if this is getting tied to coding standards that we can look at the national, see how this is changing on a national scale.
Yeah, absolutely. I think as we trend back in COVID, the kind of percent breakdown, I think, is going to shift back to something higher than where we bottomed out in September, October. But overall, looking backwards, our data and analytics teams housed in the Office of Physicians for Johns Hopkins Medicine have done an excellent job of building up Tableau visualization of exactly that utilization and breakdown data by entity, department, individual clinician, payer, and now we're moving into the health equities aspect of utilization and really trying to understand what will the long-term projections be? What is the run rate percentage? That is the question that everyone wants to know. And because it is gonna, as we start to move into 2021, we will need to start planning for what does the future look like post-COVID at some point. And that's complicated, data and analytics questions of how do we restructure schedules? How do we restructure staffing models? How do we restructure access points, decision trees for scheduling? All of that work is just kicking off to start planning for a new future steady state. Before, it was less than 0.1% of total care done through this modality. Now 25% or 50% in some areas or 80% in some areas. The entire paradigm and journey for a patient from scheduling to care to follow-up is being redesigned with that in mind. And it needs to be powered by data analytics that we're learning as we go here. But it's a big data problem that's ahead of us.
And if you're a researcher, though, you're not going to see this in Slice or Dice her. You're going to have to go to EDW or Clarity.
For a couple different reasons, yes. Epic is building in additional telemedicine reports that will be part of Epic Foundation and available through Epic-based tools, including Slicer Dicer, because of some of the real specifics and nuances to how we've built different types of telemedicine care. You can't get into the same level of granularity that we can get into when extracting it from when combining EDW and Clarity into some of the things that we've built custom into our data warehouse and then combining them together. So it does require some of the under the hood knowledge at this point.
Great, thank you.
We'll go ahead and just touch on some of the innovations that are somewhat COVID specific. And I do see that we have a question here, how has telemedicine impacted the care of COVID patients? That we'll touch on a few of those aspects here. So care innovation for new care teams. So now all of a sudden, broadly with the uptake of telemedicine, you don't have to have necessarily a physical building and a physical space to create a new clinic. And these are two new clinics that were created without those restrictions in mind. One is the COVID Ambulatory Response Team, or CART team. We care for lots of patients that don't have primary care clinicians and often rely on their subspecialty care for their general health needs. And we feel an obligation, a tie to those patients to ensure that in this new area where COVID is generally a general internist, general pediatrician question in the ambulatory space, tying those patients that we already care for to a new PCP model. And so turned on a virtual only primary care group to care for those patients that we care for other reasons, but need primary care access. So virtual only COVID related primary care. And then on the bottom, the PAC team, the post-acute care team, was a pulmonology-led Johns Hopkins home care group supported and integrated program for patients with COVID leaving the hospital with a new respiratory disease, one that we're learning more and more about, to follow them for the first 7 to 14 days after hospitalization with home pulse oximetry, Johns Hopkins home care group nursing wraparound, and then virtual escalation to pulmonologists, both in our community hospitals and in our School of Medicine, both for on-demand follow-up as well as scheduled pulmonary follow-up. We got 300 patients into that program during the surge that they touched our home care nurses 5,000 times, lots of hands-on management in the home. 3 of them were readmitted. Overall, a program that we think really helps support our patients' transition to home in this new pulmonary illness. Highlight a couple of other areas. This is work done by the Technology Innovation Center and integrated into our clinical workflows. In a couple areas. This is the clinical workflow, but there's also one for our university students and researchers as well. All of our buildings had a new queuing problem. Disney World knows how to do queues really well. Hospitals do not. So we now had patients needing to line up at our front doors and be screened. Do you have symptoms A, B, C, and D? And A, B, C, and D were changing every week as the pandemic evolved. And how do we get you in our building safely and quickly? So leveraging, human screening is the obvious, easy way to do that. That creates long, long lines. How do we automate that? Your appointment triggers an automatic push to answer pre-arrival symptom screening questions. And as many internally have said, in a TSA pre-check model, you can get your TSA pre-check badge, the green screen here, and with a date clearly visible, and walk up into our buildings. And if you have today's date and the green badge, you've screened clear, at least based on self-reported symptoms, and you can continue to proceed. So a way to optimize queuing through new digital tools. And at the bottom, engagement with patients outside of a synchronous visit has become more and more important. Yes, we can communicate with patients through patient portals. That's important. But again, even in really high enrollment systems like our own, we have 62% of patients in our MyChart portal. Pre-pandemic, by the way, that was 49%, and we're on the high end of Epic institutions. MyChart patient portal is not the only way to go. And so leveraging low tech, but integrated low tech through texting and the ways that we need to think about data privacy, security, patient identification. We've created some automated text outreaches that all of our team members can utilize. You see some of them highlighted here. Reminders to e-check in, reminders to do that COVID screen, which is the badge that you see above, but then also real on-site management through new technical tools. Please wait outside because our waiting rooms weren't built for 6 feet physical distancing. Go ahead and enter because the waiting room is now empty enough for you to enter. Some reminders more oriented to telemedicine care. A way to send video links to patients who have difficulty accessing through MyChart. Reminders that your provider's running late on video visits. That's our newest addition. Think about being in a waiting room. We've all been there where you come out and your provider's running really late. Well, I just walk into the waiting room and tell you that. In telemedicine care, it's not so simple. And so creating more automated ways to replicate that in-person workflow, problems to solve that we are continuing on an ongoing basis. Really quickly, because I know we're already here at 12:45, we're making investments in things that will allow us to expand just past the video visit. Like I said, some of that is education and training, leveraging expert clinicians here at Hopkins to teach, but it's also investment in equipment. This company, Tydo, pictured here, is one of our earlier investments that we're starting to integrate, but really addressing that core problem of remote physical exam. So what remote physical exam tools are we going to need to more successfully do an enhanced virtual visit, both inpatient and in the emergency room, as well as in ambulatory? And so working on things here, otoscope, explicitly relevant for peds, tongue depressor and visualization of the oropharynx or back of the throat, important in a winter viral season, and then stethoscope, obviously important for a variety of reasons. Continuing to think about what are the right vendors, the secure vendors, the ones that address new problems, and who are the leaders in the space. Doing the competitive landscape analysis there is also critical to ensure we pick the right vendors that are right for our patients and secure for our patients.
Yeah, this is so exciting. To augment the video visit with biosensors and what you described with oxygen sensors for remote patient care, wrapped around nursing from home care, and then specialists for within the hospital seems like an incredible model. I'm interested in Now, does the data flow into Epic? Are we able to then harness that data to look for things like things that we can alert on and conduct research with?
So our home care group, led by Mary Myers, Rachel DeSantis, Melissa Lance-Garnish, has had a built remote patient monitoring program around core diseases, congestive heart failure for blood pressure and weight, COPD and asthma around pulse oximetry and peak flow. And then diabetes for glucose monitoring. We leveraged that infrastructure, which over the previous few years had already done the work of flow sheet integration for their chosen vendors. So we're starting from a place of pre-investment, but now we need to move into a place of varied devices, various types of patients, various types of diseases, and not just targeted programs, but scalability, right? So those programs were built around, the highest risk targeted patients, clear referral pathways, but we're going to be moving into an environment where all types of patients for all types of diseases want to be able to transmit physiologic data around their disease state to their provider. That's an opportunity, but it also carries some real risk. There's a reason why the FDA approves devices. There's a reason why we calibrate blood pressure cuffs in the clinic. We don't want to make clinical decision-making off of data that has the risk of being inaccurate or incorrect. And so we're building on home care group's experience and Epic data integration for remote patient monitoring to decide on what the future state will look like for us for home vital sign integration, and more to come there for sure.
Yeah, this is super exciting. There's so much, an enormous amount of data that collected at the home, much more than we collect in the healthcare system, that could really affect how we interact with the patient and help with them with their wellness and their chronic disease management. This is great. Thank you.
Absolutely. And I will say, Paul, early in the pandemic, we made sure our remote patient monitoring data was sent into PMAP. So it is there. Our patient analytics platform. So just a couple of other things. Again, always important to bring back it to the patient. What does the patient want is as equally important as anything else. And what are they experiencing? We've had over 50,000 Press Ganey surveys sent to patients after 620,000 telemedicine visits. They're rating their provider 95 out of 100. We're above benchmark there, and we're proud of our clinicians for engaging with our patients in that way. And it's a testament to their commitment to delivering care to our patients. We did some targeted surveys, sent out 2,000 surveys to those who have volunteered to be a virtual advisor for Hopkins for a variety of reasons. We got 674 of those responses back. When asked, would you recommend telemedicine to friends and family? Median response was 9 out of 10, where 10 out of 10 is extremely likely. When asked, would you use telemedicine? How important is it to have video visit options post-pandemic? 88%, moderately to extremely important. We got some subjective testimonials. I always think, hearing it in the patient's own words, important. A couple of things that I called out here, and yes, these were selected by me. There are always feedback that are on the other end of the spectrum as well. But just to highlight some of these key points, because it really expands on, it's not just about access. Efficient and personal. I would prefer all be virtual and then only come in if necessary, i.e. a procedure. Lifesaver for the immunocompromised, really avoiding the mental health concerns of fear, especially in a pandemic. But those who are immunocompromised on chemotherapy, have an autoimmune condition, deal with fear of exposure constantly. So not just during a pandemic. And at the bottom, that maybe pandemic type situations are actually applicable to lots of other types of situations, and calling out code red air quality, but maybe that's not so relevant in our geography. But inclement weather is certainly relevant here and in Florida, where we also have our children's hospital and hurricane season. So the ability to access, even when we otherwise would have shut down during a blizzard, during a storm, the ability to still deliver care. Maybe it's not just a pandemic. There are other types of changes in our environment that would make it applicable.
Brian, I know that we have about 10 minutes left, but I think there's an important question that's coming up from Dr. Stuart Ray, Vice Chair for Data Integrity and Analytics in the Department of Medicine, and our Grand Round speaker for Informatics 2 Grand Rounds ago. And related to the patient feedback question. Dr. Ray asks, are providers being assessed for telemedicine proficiency? My mother-in-law sees 3 providers in different specialties at a health system that I won't say out loud during a recorded grand rounds. One of the providers just doesn't seem to be able to handle the IT, that well. Seems like patient feedback on telehealth proficiency could be valuable data to focus resources and training.
Yeah, thanks, Stuart. It's such a great question, and it does speak to, and I'll go back to just the surveys for a second. It does speak to actually all the way at the very beginning, talking about education. It was a really interesting problem to solve. I mean, and I'm not saying we solved it, but an interesting issue to tackle that in March and April at an academic institution, trainees, fellows, and attendings were all starting from the same playing field about how to deliver a new type of care. When you say assessed on proficiency and assessed on patient-provider interaction, assessed on ability to deliver care, that's what we get trained on through medical school, residency, and beyond, as do nurses in nursing school, et cetera. All of a sudden, overnight, we had to rapidly transition to a new type of care without the benefit of years and decades of built up curriculum. So I do think there's a major educational issue to address, but then there's a measurement issue to address on the back end. We have the benefit of our quality and reporting team led by Jenny Bailey. It's done great work to build up, again, another Tableau visualization of our patient surveys in a similar way that we build up our in-person patient feedback. And many of our delivery entities have made patient feedback and overall ratings part of how they're graded, and sometimes part of how they're graded for compensation. Into the future, we'll need to do the same to evolve to understanding, is there a statistically significant differential in how patients are viewing their providers telemedicine versus in person? We're already starting to look at where are the clinics where there's a disparate amount of audio only care going on, and why would that be? Sometimes it's certainly that those clinics care for a different type of patient population, those that have the social determinants that are maybe different, and we've already addressed some of those reasons why that may be. But there's also the possibility that if clinicians 1, 2, and 3 in that clinic are 90% video and clinician 4 is 50% video, maybe that's not a patient-facing reason. So actually looking into the utilization data as well. We're just unpacking that, but I think you're raising a really important point. It's a new educational challenge, one that I think we're wrestling with in real time.
And then Brian, one thing before you get to the public health emergency slide, which I think is really important for folks to hear about, we're going to throw it to Dr. Todd Dorman, who heads up all CME related activities at Hopkins. Todd.
Oh, thank you, Ash, and wonderful talk so far. I just wanted to make a point that actually some people may see that I'm disagreeing with you. Others may say I'm being additive. Telemedicine has been around since prior to 1930. Telecardiology, teledermatology, telepathology, telecardiology with pacemakers transmitting over telephone lines, and stethoscopy having been done, et cetera. The real issue, I think, was that there was not payment models that were built despite recognition of telemedicine. And so physician communities didn't invest in learning. But the idea of doing telemedicine, the idea of using video phones or similar devices has really been around for decades and has been done for decades. So I would suggest that COVID is not the disruptor, that it accelerated disruption that was hovering and not really being allowed to move forward because of a lack of payment models.
Completely agree. Maybe no better lead in than to wrap it up here on the slide, Todd. I mean, so these are some of the core things that made what you just said possible, but it's absolutely right. There was always an ability and potential willingness, but as with any type of job, you do need to have an exchange of value and compensation first and foremost, and then you need to be regulatorily be able to do it, et cetera. And lots of those barriers were broken down here during the public health emergency, and was the catalyst that really helped energize the ability to engage in this type of care. And some of those issues are highlighted here. I do want to ensure that we leave just a few additional minutes here at the end, but things like not arbitrarily, because it goes back to the fraud and abuse questions, but specific to Medicare and Medicaid patients, broadly speaking, patients insured by those plans couldn't get telemedicine in their home, could only get telemedicine when you're in specific types of locations, another health facility, or only if you lived in a designated rural area. Obviously, we all would acknowledge, I think, that telemedicine care may be most applicable from your home. That's where it's most convenient. So breaking down those types of site restrictions. We talked about why audio only is an important social determinant potentially for ensuring that that access remains. I'll highlight state licensure waivers, which is a very complex area of state versus federal regulatory issues. The power to license professionals inside and outside medicine is a power delegated to the states, and each state can license every type of healthcare provider. And navigating that, and you saw that graph that we deliver care to all 50 states during the pandemic, and how we need to navigate the state by state construct. Fortunately, a lot of those barriers are decreased, certainly not eliminated. We expanded from just being physician-centric to focusing on all sorts of roles that should be able to execute telemedicine and be reimbursed for it. Therapy, counseling, speech language pathology, lots of different types of services. And then during the pandemic, a flexibility that exists that I think is additive and a question where we go has been, if a patient knows and a provider is willing and it's transparent, the ability to use non-HIPAA approved video platforms for telemedicine care is a permitted flexibility from the HHS during the pandemic and the Office of Civil Rights, one that some have taken advantage of to ensure that we just use the tool that can get the care to the patient at the right time, so long as they're adequately informed. So lots of flexibilities that have been made available here during the pandemic, and we can touch on those briefly. This just goes to show you it takes a village. This is not a comprehensive list. We're missing probably a number of folks. I already know missing some of our Sibley Informatics team, Ed and Jeff, who helped us as well. But just lots of folks. I will call out my telemedicine team: Rebecca, Helen, Cindy, Steve, Kathy, Anthony, and Kelly. Just that team, supported by this long list of folks, is what it takes to transform what has been now over 500,000 visits. 250,000 patients have received care through this modality since March 16th. Just completely transformative, and a big thanks to this huge list, the telemedicine team in particular, and anyone that I missed. I certainly apologize. I try to do my best.
Great. Thanks so much, Brian. You're welcome to stop sharing your slides. We have about 3 minutes left, and we can throw out 1 or 2 questions. So Paul, I know we aren't able to get to everything, but we have a list of these questions, and our fantastic teaching assistant, Aziz, will be sure to track Dr. Hasselfeld down to get responses offline. But Paul?
Yeah, this was a fantastic talk, Brian. It is really comprehensive, and it's been fun because we've been hosting digital health conferences for the past 3 or 4 years. And every year we debate what is the tipping point functions that we needed to be able to enable telehealth. We knew a lot of the technological things were there. And Todd mentioned a key tipping point. All these things of being reimbursable, and all these things are necessary, but insufficient. It was the provider culture. The patient has to be on infrastructure to be able to do it. There has to be, it's amazing how many different tipping points there were to be able to enable this to be able to come to fruition. I guess the challenge is, in the first few days, how did you figure out, how did you scale up from zero? It's like taking a startup. How do you scale up from these 5 visits a day to 5,000? Can you describe how do you create that first initiative within the first week or 2?
Scale up quickly means you make design decisions that accelerate and sacrifice, right? So we had to make some early, clear decisions that scale and speed were important. Otherwise, thousands and thousands of patients every day were going to go without access to care. So, I do think it's an important aspect to consider. How do you balance ideal state versus next phase state? And those were some important decisions that we had to make. Like, one in particular is any given visit may end up as video or telephone. You sometimes know which one is which ahead of time. You sometimes know that a patient is saying, I want it to be telephone, but you can never know when technology is going to fail. And so how do you create a encounter that could become one of a number of different things? You could become a video visit, which is one type of visit, and build one way. It could become audio only and is build another way. Making that one encounter type is difficult to our schedulers. It's difficult to our data teams, but it was efficient for scaling. And so, trying to balance those decisions that allowed acceleration and scale while sacrificing in one end, and then figuring out how to address the sacrifice through different modalities. I mean, I think we face those decisions, every day early on. And I think it was a good, important lesson in balancing speed versus, ideal state, and recognizing that everything is always iterative.
We're going to look back in a few years as this as a case in the diffusion of innovation, of seeing what all the tipping points were to do this.
Yeah. Great. So Dr. Hasselfeld, thank you for taking time out of your busy schedule. We know there's so much going on during this surge, and we thank everyone for joining us today. It's 1 p.m. now, and we look forward to seeing all of you back on February 11th, 2021, as we resume our Informatics Grand Round series. Please reach out via jhinformatics@jhu.edu if you have any questions about the program. Brian, like Dr. Ray wrote in the chat, this was an excellent presentation, very informative, lots of real-time data, lots more work to be done. Be well, everybody. Thank you for joining us.
Thanks, Ash. Thanks
Stay
all.
safe.